Discussion today is a 9-month-old infant with progressive abnormal enlargement of a head from the third month after birth with the vomiting and lethargy. History of presenting illness, I'll ask about history of vomiting, poor oral intake, a history of fever, cough, or any breathing difficulty, history of diarrhea, history of weight loss, and history of onset and progression of these symptoms, and in history of any irritability, lethargy, or history of any loss of consciousness. Onset and increase in head circumference from the third month should be asked. Past medical and surgical history, any history of recurrent respiratory tract infection, any history of congenital heart disease, any history of bacterial anomalies, associated anomalies, any history of neurological anomalies, any history of bronchial asthma or muscular dystrophy, any previous history of surgeries like VP shunts are done. Then in antenatal history, I'll ask about the trimesters being uneventful or not, any history of diabetes, hypertension, or thyroid disease, or any history of torch infections in mother, and any history of maternal drug intake or irradiation. In birth history, I'll ask about the term or preterm delivery, about whether the delivery is normal vaginal delivery or a lower segment cesarean section, or any history of any complication during delivery, any complications after delivery, like weight of the baby to be noted, and whether the baby cried immediately after birth or not, any history of asphyxia cyanosis after birth, and any history of NICU admission. In family history, I'll ask about consanguineous marriage and any history of similar presentation in the family members. In developmental history, history of head control should be noted, and whether the baby shits and walks with supports or not should be noted. Any history of delayed milestones should be noted. And in immunization history, I'll ask about whether the baby is immunized up to age or not. Any adverse reactions to immunization to be asked. In nutritional history, I'll ask about the history of poor oral intake or failure to thrive, any history of vomiting, any history of bowel and bladder habits abnormalities should be asked. And in drug history, I'll ask about whether the baby is allergic to any drug, or if the baby is on any previous medications like diuretics or anti-epileptic medications. And in general examination, I'll check whether the baby is alert, active, or lethargic, and anthropometric measurements like height, weight, and head circumference to be noted. I look for pallor, icterus, cyanosis, clubbing, and lymphadenopathy, and pedal edema. And I'll examine whether the child is febrile or not. And in head to toe examination, I'll look for a large head circumference on the frontal bossing, and bulging anterior fontanelle is present or not, and dilated scalp veins are present or not, and sutural diastasis, and associated facial anomalies like cleft lip and cleft palate is present or not. And in special signs such as sunset sign and McEwen sign to be noted. Sunset sign is the upward gaze palsy. McEwen sign is cracked pot sign, which is on percussion. There will be cracked pot sound on the dilated ventricles. And signs of dehydration such as dry mouth, sunken eyes, and skin turgor to be noted. Any spine deformities and meningomyelocele to be noted. In vitals, I'll note the respiratory rate, heart rate, temperature, and saturation. And systemic examination, I'll look for cranial nerve examinations and motor examination, tone and reflexes to be noted, and whether the baby is active or lethargic. In respiratory system, I'll look for bilateral symmetrical chest movement, bilateral air entry present or not. I look for any stridor present or not. In cardiovascular system, I look for heart sounds and any palpable thrill or murmur present or not. In parabdomen, whether the abdomen is soft or tender, and there is a presence of any palpable mass and bowel sounds present or not. Then in airway examination, I'll look for adequate mouth opening, any abnormal facial asymmetry present or not, or any cleft lip of palate present or not. In investigations, I'll ask for CBC, RFT, electrolytes, random blood sugar, blood grouping and typing, ECG, and echo to look for cardiac anomalies and congenital heart disease. CT, MRI, and chest X-ray can be done. In CT, in given Evans index and ALV can be noted. Evans index in CTMH is a ratio of a maximal width of the frontal horns by the maximal inner diameter of the skull at the same level. The ratio of more than 50% indicates hydrocephalus. In ALV is the anteroposterior diameter of the lateral ventricle index. It is a quantitative measurement to evaluate the size of the lateral ventricle, particularly useful in normal pressure hydrocephalus. The treatment options available for this patient is medical treatment and surgical treatment. Medical treatment are diuretics like acetazolamide, which is a carbonic anhydrase inhibitor, can be given 25 mg per kg per day, and furosemide 1 mg per kg per day. Anti-epileptic medications can be given. Surgical treatment include choroid plexectomy, endoscopic third ventriculostomy, and shunts between the ventricles and other body cavities like ventriculoperitoneal shunt, ventriculoatrial shunt, ventriculopleural shunt, ventriculosubgaleal shunt, and lumboperitoneal shunt. Mm. Hydrocephalus definition: it is a condition characterized by an abnormal accumulation of CSF within the brain, causing the ventricles to enlarge and the pressure inside the brain to increase. It may be due to the mismatch between the CSF production and absorption, resulting in increased intracranial pressure. The classification of hydrocephalus may be of 4 types. Depending on the functional, it may be communicating or non-communicating, and pathological, it may be congenital or acquired. Acquired due to trauma, tumor, or infection. Congenital anomalies like Dandy Walker syndrome, aqueductal stenosis, Arnold-Chiari malformation can also cause hydrocephalus. Age-wise, like it may be pediatric, juvenile, or adult. Clinical conditions like acute or chronic, whether high pressure or normal pressure hydrocephalus, arrested or ex vacuo hydrocephalus. And anesthetic concerns in this baby are pediatric age group, large head leading to difficult airway, difficult mask ventilation, and difficult intubation, difficult positioning, hypothermia due to large head exposed to the cold environment. Then due to dehydration, IV access may be poor, and dyselectrolytemia and hypoglycemia are to be looked out. Delayed gastric emptying causes risk of aspiration and risk of air embolism and neuronal injury due to surgery. The anesthetic goals are to prevent further increase in ICP and maintain cerebral perfusion pressure, prevent hypercarbia, hypoxia, and hypotension, ensure smooth induction and smooth emergence. Preoperatively, I'll explain the parents about the anesthetic plan and obtain informed consent from the parents. NPO guidelines, which is 6 hours for solids, 4 hours for breast milk, and 2 hours for clear liquids. If a patient is on diuretics, I'll ask for serum electrolytes on the day of surgery and optimize the hydration status preoperatively. To continue, anti-epileptic medications. Antibiotics to be started if the patient is febrile and have active infection. I will avoid pre-medication because it can mask neurological status of a patient and may cause hypoventilation also. OT preparation, I'll set the OT temperature to at a higher level and make sure the anesthetic workstation and suction are working and apparatus are checked, and prepare airway equipment. I'll keep the difficult airway cart and video laryngoscope ready, and anesthetic drugs and emergency drugs to be loaded and kept ready according to the weight of the baby. After confirming the NPO status and inform the consent, I'll shift the baby to the OT. Place the child on the warming mattress and cover the head to prevent the hypothermia. Rolled sheets to be placed under the shoulder, and the trunk should be placed under the pillow, and while the head is placed on the neutral position with the head ring. The positioning is very important in hydrocephalus. Standard ASA monitoring to be attached with ECG, SpO2, NABP, precordial stethoscope, and temperature monitoring to be done. If a patient is hemodynamically unstable, invasive BP monitoring can be done. Induction, avoid sedative pre-medication. The plan of anesthesia will be GA, rapid sequence induction, with ET tube and control ventilation. If poor IV access, I'll secure IV under inhalational sevoflurane induction. If IV access is present, then IV induction using thiopentone 3 to 5 mg per kg or propofol 2 mg per kg can be done. I'll avoid ketamine. Muscle relaxants like rocuronium or succinylcholine can be given. During laryngoscopic response, to reduce the laryngoscopic response, lignocaine on 1 mg per kg can be given. Gentle laryngoscopy to be done, and ET tube of appropriate size to be secured. And the patient is kept in supine with the head up of about 30 degree to improve the venous drainage. And fluids like NS or oral can be used. I'll avoid dextrose containing fluids, and the fluid warmers can be used to avoid hypothermia. Maintenance, positioning head up to 30 degree with minimal neck flexion and a rotation to improve the venous drainage and prevent any rise in ICP. Sevoflurane of less than 1 mg, air and oxygen can be used. I will avoid nitrous. Non-depolarizing muscle relaxant like atracurium can be used for maintenance, and I will maintain normothermia, normocapnia, and normotension. During incision and subcutaneous tunneling, there will be an increased response. So at the time, local infiltration or deepen the plane of anesthesia, and low dose fentanyl, remifentanil, and paracetamol can be given. During the cannulation of the ventricle, there might be sudden fall in BP, and we have to be ready for that. Extubation, it depends on the hemodynamic stability. If the patient is hemodynamically unstable, I'll opt for elective ventilation postoperatively. If the patient is hemodynamically stable, and a smooth emergence is mandatory, and antiemetic of about 0.1 mg per kg should be given 60 minutes prior to extubation. Ensure the baby is adequately warmed and the neuromuscular blocker is completely reversed, and the child is completely awake. Then I'll extubate the patient smooth, and post-op care to be given. And post-operatively, adequate analgesia to be maintained. Paracetamol or diclofenac suppository can be given. Low dose fentanyl can be used. Maintenance of normothermia, normovolemia, and normotension is important in post-operative period also. And close monitoring of the vitals and urine output to be done. And frequent neurological assessment and status of a baby to be done in the post-operative periods.
Okay. So this is a short case scenario which has been given to you. Okay. I allowed you to present the whole thing because it will benefit the other PGs to know about this condition, like the definition, classification, all these things. But in the exam, I will not allow you to go through all these details. So how did you make out? Here it is not overtly given that it is a case of hydrocephalus. The case scenario that is given to you says that a rapidly increasing size of the head in a 9 months old infant observed from the 3rd month onwards. Now, if that is the case, how do you know that it could be only hydrocephalus? Why not it be a tumor?
It is acute and with progressive enlargement. Because
progressive is not acute. It has been happening gradually. What is the normal head size in a normal infant or newborn?
33 to 35 centimeters.
35 centimeters. And what is the correlation between the head size and the chest circumference?
Chest circumference is 2 centimeter less than the head circumference.
So head is larger in all newborn babies, and it should gradually increase by what will be the increase according to the growth?
From up to 3 months, it will be 2 centimeter per month. Up to 3 to 6 months, it will be 1 centimeter per month. And 6 months to 1 year, it will be 0.5 centimeter per month. And from 1 to 3 years, it will be 0.5 centimeter per year. And after that, 1 centimeter per year. Sir. Attains the adult stage by 6 years.
Rapidly increases, then becomes stabilized, then it again some increase, and then it stops. Isn't it? So here, if the parents find it very abnormally enlarging, it could be due to a hard mass inside or a fluid. We cannot say. But if it is a hydrocephalus, and if you are allowed to examine the child, how will you confirm that it is only a hydrocephalus?
That sound, percussive sound.
Baby. So what are all the features that you will see in the head?
there will be
all of them.
yes,
Dilated veins.
Dilated ventricles, McEwen sign.
Fontanelles will be very tense and
Very
bulging.
Bulging fontanelles.
Suture lines will be separate. Okay, so these are all the adaptations. Now, what will happen if, and already in the case history, it is given that child is lethargic and has a vomiting. Also. What does it indicate?
It indicates that the compensation about the
pressure. ICP pressure is now
ICP is increased.
What is the normal ICP in a child? This infant, what should be the normal ICP?
5 to 7 millimeter of mercury.
Less than 1 year old child or 18-month-old child will be 5 millimeters. The suture lines have not yet fused. The fontanelles have not closed. So in that situation, will it be able to go up to 5 millimeters? ICP is only 2 to 4 millimeters in the newborn and infants. Okay? Only when the skull becomes a rigid cavity, the pressure can increase.
Yes, sir.
The pressure will not increase. Okay, so in a normal infant, it should be only 2 millimeters to 4 millimeters maximum is the intracranial pressure. But if a child has started developing more than 5 millimeters up to 10 millimeters, this will start exhibiting all the features of increased ICP. Okay? Why you are worried about ICP? What are the complications that it can produce? What is the risk of allowing the intracranial pressure to go up?
Rise in intracranial pressure can cause herniation and brainstem compression. Child may go for apnea and arrest, respiratory arrest, cardiac arrest.
What is it called? What is that particular herniation where child can go for cardiorespiratory arrest is called? You said the brainstem can herniate.
Brainstem herniation.
Through which hole it will herniate?
Foramen magnum, sir.
Foramen magnum. So when the brainstem goes and tries to enter the foramen magnum and downwards, what is that called?
Uncal herniation.
Uncal means it is the herniation through the dura mater, not through the foramen magnum. It is called coning.
Coning.
Coning. Yes, okay? Yes. Coning is the greatest risk of any ICP rise in both adults as well as in children. But if it doesn't go up to that extreme end of coning, what can happen to the brain perfusion?
Cerebral perfusion pressure will be affected, sir. So ischemia.
What is cerebral perfusion pressure? How do you calculate it?
Mean arterial pressure minus intracranial pressure, sir.
Intracranial pressure plus with only you have to subtract only intracranial pressure or some other
and central venous pressures.
Central venous pressure, CVP also. Venous pressure, cerebral venous pressure, not central venous pressure. But cerebral venous pressure is usually considered as negligible or zero. So we normally take only MAP minus ICP is equal to CPP, which is very important for perfusion of the brain tissues. And if the pressure goes between 5 to 10, what will happen? If it goes beyond 10 centimeters and millimeters, what will happen? Is there a difference at the ranges of pressure?
Beyond 10, there will be Cushing's triad like hypertension, bradycardia, and irregular respiration can occur.
That's the clinical presentation. But what will happen to the perfusion? The question is, what will happen to the perfusion? There is a difference in these two. Between 5 and 10, you will have focal ischemia. Some parts of the brain only will become ischemic. Okay. And if the pressure goes beyond 10 millimeters of mercury, it will be global ischemia. The entire brain will be suffering from hypoxemia. Okay, 5 to 10 millimeters, focal ischemia will enter. Beyond 10 millimeters, it will have global ischemia, it is then going to be problematic. That is the reason why you want to remove the, reduce the pressure as quickly as possible. Now, by doing the shunt, are you completely clearing the problem, or is it a temporary solution?
It is a temporary solution, sir. We are diverting
Usually,
the
it's a temporary
CSF.
solution. Okay? So you have to identify the cause. That is why the etiology is important. And sometimes all the questions may be directed towards the physiology of CSF. What is CSF? How is it formed?
It is formed from the choroid plexus. Choroid plexus secretes the cerebrospinal
What is the
fluid.
mechanism of formation? Where is it formed
Ultrafiltration
from?
of
Ultrafiltration of the blood.
blood.
Okay? Just like your glomerular filtration, the choroid plexus also has a filtering capacity, and your blood is filtered by ultrafiltration method to take out the watery content. What is the role of CSF in the skull or on the vertebral column? Why CSF is being produced? What are all the functions of CSF?
It provides a cushioning effect and buoyancy to the brain, and it maintains the cerebral volume.
First and foremost is called buoyancy. The word you must use is called buoyancy.
Buoyancy. Yes.
When something floats in water, it reduces its weight. Just like Archimedes found out is that when he was sitting in the Eureka, he shouted and went out. He said, so the buoyancy prevents any injury happening when there is a sharp hit or a turn happening inside a rigid box like your cranium. Okay? That is the first and foremost purpose. It prevents the shock to the brain, just like a shock absorber. Is there any importance of CSF in respiration? How does your respiration take place? What is the role of carbon dioxide in respiration?
Carbon dioxide acts as
Can
a
it dissolve in
stimulus.
water? Carbon dioxide, is it soluble in water or not? Your body carbon dioxide always dissolves in water to form what? Carbonic acid.
Carbonic acid.
Plus H2O. Carbonic acid. Carbonic acid is a stable acid or a weak acid?
Weak acid, sir.
Weak acid.
Weak acid. It will break down into
H plus HCO3.
bicarbonate and hydrogen ions. H2CO3 will divide into HCO3 and H plus ion, isn't it? And the hydrogen ion is important for triggering your respiratory center. Okay. So the normal respiratory control is mainly because by the carbon dioxide getting dissolved into the CSF and producing hydrogen ions, which is responsible for the triggering of respiratory. So the second important point is that. Third important point is it is the transverse medium for supplying the nutrition to the brain tissues, glial tissues. Okay. So these are all the important things that you have to remember. And what is the route of circulation of CSF?
From
what
the
is the total quantity of CSF produced per day?
200 ml, sir. Total
volume.
150
ml. And how much is present inside the cranial cavity? How much is present in the spinal cavity?
In the cranial cavity, there is 70 ml, sir. Out of 200, 70 ml is present in the cranial cavity, and remaining is present in the spinal column, sir.
So, what is the importance of spinal CSF? What will happen if there is full CSF in the spinal canal at all?
The nerve root is bothering.
The
nerve roots, the spinal nerve roots will bothering this CSF.
Spinal nerve roots, they have to protect the spinal nerve roots. What is the main important function of the spinal CSF? It supports the meninges of the cranial cavity. Okay. Why do you get post-dural puncture headache when there is a loss of CSF in the spinal canal? The support offered by the column of CSF in the vertebral canal is lost. So what happens? The basal meningeal layers inside the cranium, they get stretched by the weight of the brain, and these meninges are innervated. Sensory nerves are there in the meninges, and this stretching only produces the so-called post-dural puncture headache mechanism is only that. Okay? So spinal
Yes,
CSF is very important to support the weight of the brain, especially when you are in the erect posture. That is why PDPH becomes more aggressive when the patient is in the erect posture rather than in the lying posture. When gravity is taken away, PDPH intensity comes down. Whereas when you are in the erect posture, because the column of CSF supporting the cranial meninges and
cavity.
brain is not there, that is the main purpose of that. Okay? So,
Yes.
what is the route of circulation of CSF? Where does it originate and where does it end?
From the choroid plexus, it is secreted, and
Ah,
from the lateral ventricles through the foramen of Monro, it is transported to the third ventricle. From third ventricle through aqueduct of Sylvius, it is going into fourth ventricle. From the fourth ventricle, it enters the spinal canal through three foramens, two lateral foramen of Lashka and central median foramen of Mejendi. It enters the spinal canal, and through the spinal canal it circulates, and it is reabsorbed in the arachnoid villi in the subarachnoid space.
venous system. Okay, so it
Venous system.
originates and then gets this is the whole circulation. So, what do you mean by communicating and non-communicating classification?
Communicating means all four ventricles will be enlarged, sir. In non-communicating, maybe it may be due to obstruction by tumor or infection at a particular ventricle.
Well, okay. Common, which is the common site of obstruction? If it is non-communicating,
Uh, the foramen of Monro, sir.
aqueduct of Sylvius.
Aqueduct.
Stenosis of aqueduct of Sylvius is the most common site for obstructing or non-communicating type. In the communicating type, it is a fault either of overproduction of CSF or decreased absorption of CSF, with the passage being intact and open all the time. Okay, so that is the
Yes.
main difference between these two. And this communicating type will be amenable to medical treatment, as you said, for acetazolamide and furosemide. All these things will work out only if it's the communicating type of hydrocephalus. On the contrary, if it is a non-communicating type, because there is a mechanical obstruction, there is no use giving drugs which will reduce the production. They may not help in much. So there you require only a drainage procedure or a shunt procedure. Okay, so that is the importance of knowing the etiology and exact mechanism of this particular problem. Okay, so
Yes,
when
sir.
you discuss about this, they will ask you how you identify hydrocephalus and what are all the problems you will face in. So they may not go into the details of all this pathophysiology and all these things. They may immediately ask you, have you ever seen a case of efficient being done in your training period so far?
Yes, sir.
You have seen, very good. Then it is quite easy to remember. And the challenges of pediatric anesthesia are all there. Okay, the same airway problem, the reduced
Hypothermia.
metabolism and all these problems are there, common to pediatric. So I'll just go to share my screen with you and quickly go through